Hi there. Welcome to ComplyPlus Presents. I'm joined again by Dr. Richard Dune over in the Philippines. How are you doing, Richard?
I'm doing great. Getting used to the weather here. Yeah. How are things in England?
Yeah. Things are pretty well over here. We still seem to be having a nice summer, so that's good.
Mm,
Had a couple of heat waves earlier this week, so yeah, we'll see what the bank holiday weekend's got in store. That usually brings us back down to earth in the
mm,
UK. So yeah, we'll see how that goes. But
yeah.
look, thanks for joining me this week. Slightly different topic again, but something that has been in the news quite a lot recently. And we thought, particularly with your background, but obviously some of the businesses folks over the last few years has been a lot in this area. We thought it would be good to do a quick episode on this today and increase awareness in this area because it's a big talking point at the moment that seems to keep resurfacing, unfortunately, as well. And that is the DNACPR and ReSPECT when we talk about resuscitation in care settings. From your side, Richard, probably best to give people a bit of a background on what those terms, what they actually mean. So, what is the DNACPR and the ReSPECT?
So DNACPR, it stands for Do Not Attempt Cardiopulmonary Resuscitation. So, when somebody stops breathing, the heart stops. Normally, what we do straight away is we get the ambulance over and we start pumping on their chest and giving them rescue breaths, depending on what setting we are in. So, when somebody has a form completed to not attempt resuscitation, it means that a clinical decision has been made by a healthcare professional. So we're talking about senior doctors here, where CPR was deemed to be unlikely to be successful. So CPR is then when you're doing cardiopulmonary resuscitation, so chest compressions and rescue breaths to try to bring the person back to life. So it's been deemed that it's unlikely to be successful or not in the person's best interests based on their condition, the prognosis, and preferences. So, what's important to stress here is that DNA CPR is not a decision to stop all care. And that's where a lot of the challenges we've seen from the COVID inquiry to another case that was in the news that I know we're going to talk about in this series. It applies to CPR in the event of cardiac or respiratory arrest. So the heart has stopped or the person stops breathing. The individual should still receive all the appropriate and necessary treatments. For example, they can still get pain relief, they can get antibiotics, fluids, oxygen therapy, personal care, emotional support. So DNA CPR does not mean do not treat. There has to be proper legal steps that are taken and justified as well. So I don't know whether you want me to talk about respect as well.
Yeah, I
In
think
this instance.
it's worth just yeah, because
Yeah.
I know they sometimes get, like you say, bundled together, but there is obviously
Mm.
some differences there. So I think it'd be good
Mm.
for the listeners to understand the difference.
And that is the key to realize that they are different. People are treating them as if respect is now replacing DNA CPR. So respect stands for Recommended Summary Plan for Emergency Care and Treatment. So this was introduced. This is the purple form. The DNA CPR traditionally was the red form. It's a paper form that was introduced just before COVID, and then it's more in use now across all the NHS settings as well as in primary care. So it means this was developed to move beyond just one dimensional decision like DNA CPR. So it creates a more holistic, person centered emergency care plan. So, with respect, we're talking about the process that is designed to involve the individual in a meaningful conversation about what happens to them, what matters to them, what are their values, their goals, their fears, and priorities. You are putting together what's clinically appropriate and the person what would they want or what would they not want in the case of an emergency. So unlike DNA CPR, which focuses purely on CPR, respect plan covers a wide range of interventions and can include whether people want treatment with antibiotics or not. Maybe it's an acute admission, they have underlying conditions already, whether they would want to be admitted to hospital in the first place. Some people refuse to be admitted to hospital, and as long as they've got capacity to decide that, then it's up to them. And whether non-invasive ventilation should be considered, and definitely whether CPR should be attempted. So when you look at both of them, just to take us back to the basics again, they are not just acronyms on a form that people then say, oh, is it there or is it not? These are decisions that carry huge legal, ethical, and emotional weight, and they they're misunderstood and misapplied, sadly, with disastrous consequences, and people die or people deteriorate. So the consequences can be catastrophic, and people need to be able to distinguish between the two and what they mean in practice as well.
Excellent. So if we look at, say, a respect form, then some of them might say things like "do not attempt CPR." Some of them may also say things like "administer antibiotics" or "transfer to hospital" in some situations. There's different things that can be put on that form. So, like you say there, there's a case still for action. It's not just a tick box.
Definitely, the case that triggered this particular conversation, it was actually in a care home setting where the instructions were misunderstood. People thought that you have a respect form, so it means you're not going to attempt CPR, but actually they should have indeed attempted CPR. So you need to understand the nuances here to say, look, it's a values based document. So you can say do not attempt CPR or administer IV fluids, because IV fluids can be needed to sustain life for the person, or as part of their treatment if they're dehydrated, right? So why would you stop them? Like in this heat actually that we're talking about, we're having heat waves. People may need IV fluids just to get past that,
Yeah,
isn't it? So
yeah,
or it can say admit to hospital if a reversible cause is suspected. For example, if they've got a chest infection or urinary tract infection, you can treat that with antibiotics and give them IV fluids. So why wouldn't you admit them to hospital for that? Of course, if their heart stops, that's a different story altogether. So yeah, some may say offer full treatment, excluding intensive care. And I've met quite a lot of people who say, I don't want to be taken to intensive care no matter what happens. And it's their choice as long as they're making an informed choice, and they know the consequences actually of not being transferred to ITU, then it's up to them. So it has to be tailored, and the aim is to help clinical teams make the right decisions in high pressure situations. And even care homes, like in this case, the paramedic is asked to come out, then they're making a decision under high pressure and they make the wrong decision. So here's the problem now. In many settings, under high pressure, people don't always take time to interpret these forms correctly, right? So some assume that respect means DNACPR is replacing DNACPR. It's not. Or if a person has an emergency plan in place, then all intervention is prohibited, which is not true, right? So let's get back to the earlier point where we're saying, look, people, why do people end up with a DNACPR? So maybe they have an advanced illness, right, such as late stage cancer or advanced heart failure or multi organ failure. The outcomes are not going to be good there. There's no point doing resuscitation. It's not in the person's best interest. Or maybe they've expressed a clear wish not to be resuscitated. And if they have capacity to do that, that's fine. It's their decision to make. So sometimes the clinical team may believe that CPR would be futile or cause more harm than good. So it's about weighing what's good for the person. And sometimes actually that decision is to be made by clinicians, despite what the family might be trying to pressurize you to do or what they say their wishes may have been, right? And also, if person is nearing the end of life, the focus now is on comfort, dignity, and a good death. There's no point trying to jump on their chest to try to resuscitate them when they're at the end of life. So what's critical here, and this is a vital point, is that DNA CPR decisions must always follow proper clinical assessments. It has to be justified. Capacity assessment has to be done where relevant. And if the person lacks capacity, it can still be made in their best interests. Family obviously will be involved as well. Legal proxy may be involved, but we follow the Mental Capacity Act, which talks about the person's best interests.
mm. Excellent. Thank you for that. Hopefully, that will put to bed a few myths, but also give people a lot more detail around DNA CPR and respect, and particularly the forms and the sort of paperwork that comes with that. Particularly in care settings, as I say, when you're looking after multiple residents and so on, it's really important we know, like you say, the law around it, but what they actually stand for, these forms. So I think that's very useful. I want to take us back to sort of the beginning of the conversation where we said, look, we're doing this podcast today. It's triggered us to do it based on an incident that happened. So if you wouldn't mind giving the listeners a bit of insight into the article you wrote earlier this week regarding the heartbreaking case that you covered. What exactly happened in the case of Kathleen Gregory?
Yes, this was a really sad case that was published by the BBC and many other news media houses. It's about Kathleen Gregory, who was 74 years old. She was a resident at Beckhouse Care Home in Suffolk. So what happened is that during her lunch, she was having a lunch, she choked, and her airway was blocked, and medical emergency was started, including calling for an ambulance. And the paramedic arrived, and they saw that she had a respect form and assumed that she was not for resuscitation. And this assumption was wrong. So I wrote an article, an opinion article that we put on LinkedIn, and we got a lot of discussion around that actually to say, look, there's lack of understanding here about the distinction between DNA CPR and ReSPECT. What do they actually mean in practice? And you know that we provide resuscitation training at all levels.
Yes.
And this is one of the things that we keep seeing actually. This is sad because we keep seeing it in practice. Although the guidelines are very clear, but actually there's a misinterpretation of the guidelines. People think that respect automatically means that you're not going to resuscitate them, and that is completely wrong. So what went wrong here in this case was that the respect form actually did not say no CPR. They should have done CPR because part of the choking treatment actually, chest compressions can help remove the object from the airway. That's part of the treatment for choking. If you look at the guidelines from the Resuscitation Council, so they misread the document, and no attempt was made to resuscitate, and she died sadly. And it went to the coroners as an unexpected death. Although you called it accidental, the coroner said it was potentially preventable. So we're not saying that she would have survived, but had they done followed the guideline and followed the choking guidelines, they would have actually done chest compressions, which would have helped to remove the object. So a future of deaths report was issued, and rightly so, because we're now using this as a learning case. And it's sad though, but that's how we learn in health and social care. We use case studies to actually say, look, how do we prevent these deaths or these situations where people could potentially have been saved? We're not saying that she would have survived, but actually what can we learn, and what can other care providers, particularly we're talking about people in the community here, domiciliary care companies, care homes, and other community settings where they don't have trained professionals. In this case, the sad thing is that paramedics actually, they are first responders. They've higher level training, and I'm quite shocked that a paramedic did not know how to read the respect form properly. So there's a lot to learn here and a lot to talk about.
Excellent, excellent. And ultimately, those decisions cost her life, didn't they?
Potentially, yes. Like the coroner said, it could have been avoided, right? So the core
Mm.
problem wasn't lack of paperwork. The paperwork was there, but there was poor interpretation of the paperwork under pressure. So we go back again. I always talk about decision making under pressure in care settings, right? And I think it's an under researched area where we really could do more. Resuscitation Council UK are now looking more into human factors and adding them as part of the resuscitation training and even first aid training. We need to use such cases as part of the simulation training. And there was no escalation or second opinion in this case because once the paramedic arrives, the care team automatically deferred everything to the paramedic. And then if the paramedic says, well, they're not for resuscitation, then everybody automatically believes the paramedic because they are occupying a senior position in this case. Right? So there's lack of clarity as to what respect actually means. It shows that there's a fragile chain of decision making here in care settings, especially when emergency documents are misused and misunderstood. It's a challenge to care home owners and managers
Yeah.
actually to really change the way we're doing training in first aid and resuscitation.
Mm. And unfortunately, this isn't an isolated incident, is it?
No, no, not at all. Like I said, actually, in our own training, even with healthcare providers, people that are working in hospitals, you'll be shocked how little people know about this because people tend to brush over the legal and ethical issues and focus on the practicalities of resuscitation. You have to understand the theory. You have to understand the legal framework and regulatory framework. You have to understand your role and responsibilities. You should not rely on a doctor or a nurse or a paramedic. Everyone has a role to play here, and everybody needs to know because, at the very least, everyone should be doing basic life support level 2. And in most care settings, they're doing emergency first aided work anyway, which is probably a more comprehensive course, or they're doing first aided work, which is a 3-day course in full. So, blanket CPR orders, these are some of the issues that we're seeing. During the pandemic, particularly when they were reviewing what happened in the pandemic, why so many older people died in community settings, especially care homes. It's really magnifies the issue where there were blanket DNA CPR orders to whole groups of people. That was shameful, really, for the government to not realize or even overlook that. And sometimes, actually, just based on age or setting where people are, then no capacity assessments done, even when required by law. So, of course, if you are not doing things as required by law, you are breaking the law. That's it. No two ways about it. Then families and legal representatives sometimes excluded from the conversation, or sometimes even families, their opinion coming in over the best interest of the person. So our job and our duty is to protect the best interest of the person. Then verbal orders being issued as well without proper documentation. Frontline staff sometimes left to guess what needs to be done, what should be done. So not just bad practice here, we're talking about breaching the Mental Capacity Act. That's a law. Violating the Human Rights Act. That's a law as well. And directly contradicting the CQC regulations on consent, on safety, on governance. It's not just a paperwork issue. We're talking actually about complete governance failure with real life consequences and lives being lost, just because people made assumptions and they did not understand the documentation in place, and no effort is made sometimes for management to make sure that people understand it. Because there has to be a policy supporting the training needs, and then the training delivery and the practicalities as well on how people are using these policies in practice.
Mm. Excellent. So, if we sort of home in on this to sort of understand the real implications and what's really going on out there, and we start looking at data, um, how widespread is this issue?
Yeah, we were looking at this data when we were preparing the blog that we put on LinkedIn.
Yeah.
CQC data, they found that 1 in 10 care home inspections uncovered inappropriate DNACPR decisions, right?
Okay.
And
One in
only
10. Yeah.
44% of the care providers had comprehensive training around emergency care planning. So people who have a policy in place, they will have ticked a box to say they've done the first aid training or the basic life support training, but actually it's not linked with the emergency care planning at all. There's nothing in the care plan
Yeah.
that links to the
There's no
training that
connection.
has
Yeah.
been done. And then we're looking at the BMJ quality and safety studies as well, where around 60% of DNA CPR decisions were not properly discussed with the individual or their family. So that means so many people out there don't even know a DNA CPR has been made. So some people were shocked that their mother or grandmother or elderly relative had DNA CPR in place, which they were not aware of.
Really, when you break those numbers down, 1 in 10 care homes, I
Mm.
mean, which is quite a big number, 10%.
Yes.
If you base it like that, over half the providers don't have the comprehensive training
Yeah.
because only 44% of them do. And then around 60% of decisions weren't properly discussed with the family, which again is over half of
Yeah.
all the cases that are going on in the UK every single day, every single year. So, yeah, pretty harrowing statistics, really. Yeah.
It is because when you all you need to do is to go on the CQC website and look at the organizations in care settings that need improvement. All this data is there, and it's absolutely shocking because think of your loved one. To say any of us actually could end up in a care home, or our loved ones could end up in a care home, and 10% sounds pretty bad, but when you go to 40%, 60%, these are huge numbers, which is really worrying, and a lot of these are avoidable. It's about linking policies with the national guidelines and making sure that training is aligned to those guidelines and also can be applied in practice. So you're talking about what are the learning outcomes of courses actually. If people can go out there and discern the difference between different instructions in a respect form and be able to act on them, that's really worrying. So frontline staff actually are being left unprepared sometimes in critical moments, and sometimes it's not their fault because if the company is bringing in trainers, whether it's in-house training or it's external training providers, or maybe they've done some course online and they've not done the practical, there's no supervision in place. It's quite worrying. I mean, 50, 60%, I wouldn't have thought those numbers were even likely, but it's absolutely shocking. You're right. Yeah.
Mm. Yeah, like you say, particularly here in England, it's quite worrying. I think numbers based on where you would expect things to be here. So
Mm.
yeah, and like you say, it goes deeper than just training gaps, doesn't it?
Definitely, definitely, because you're looking at systemic governance breakdowns. You and I keep banging on about Regulation 17, good governance. And I think one of the biggest problems here is that like I spend most of my time working in healthcare, but I've done quite a lot as well in social care and primary care. In healthcare, you have the advantage of having a clinical governance framework. This is a tried and tested system that is evidence based, and the care sector is lagging behind. I know that there are a lot of efforts now to try to improve things in the care sector, but until we have a well structured framework that organizations are actually required to have in place as part of their compliance, then we're wasting our time because a lot of things that are being done right now are superficial. People are not doing proper risk assessments. People are not mapping things. There's lack of connectedness. Documentation is out of date and unclear sometimes. Audit trails as well as to why decisions were made and who made those decisions. Staff have limited or no access to emergency care plans in real time. What happens on a night shift or a bank holiday or a weekend when the management are not there? Because you and I have gone to organizations where everything is dependent on two or three key people. If one of them is off, they'll fail every single audit because nobody else knows how things should be done. So it's not enough to have a policy or a folder somewhere, or even to have a digital system. If staff don't understand the forms or can't access them when it counts, people suffer. And
Mm.
it's not just about poor training, like you rightly said. It's about understanding of risk, awareness of risk, and also our risk appetite. Some risks actually are not worth taking at all. But also you need to think about insurance. What sort of liability are we taking as organizations? Then patient safety, like in this case, we're talking about service users in the community, whether they are residents or clients in a domiciliary care setting. All that matters because first and foremost, it's about their outcomes. And if we're not even meeting the basic outcomes, then there's not much hope for anything else without sounding very alarming there.
We've discussed a lot of these themes, particularly over the last couple of months worth of podcasts. The connection between policy, between training, between competence and application. And I think this is another, unfortunately, it's a sad case, but it's another example of those things being disjointed. And many providers just, like you say, ticking boxes. Have they got this? Have they got that in place? Have we done this training? When is this certificate due to be done? But where's the measuring of effectiveness? Where's the, let's say, the scenario based training where you put people in these sort of high pressure situations and then see how people respond and if they can apply the knowledge? So, yeah, I think some very good points made there. If we now look at sort of the legal and ethical duties, I wanted to dig into those legal standards. So, if a provider's listening right now, what must they get right in this area?
So there are three key elements that I want to talk about. These are pieces of legislation, right? So whether you're an owner of a care home, a director, you're a registered manager, you need to think about Mental Capacity Act. You need to think about the Human Rights Act, and you need to think about the Equality Act. That's really the core of what we're discussing here. So, Mental Capacity Act, if can person make a decision, right? It's their decision, full stop. There's no discussions about that as long as they have capacity. If they lack capacity, then we need to, if we doubt their capacity, then we need to do the appropriate assessments so that in the end, we can make decisions in their best interest. So we still need to involve the family, legal proxies, or if they're attorneys or court appointed deputies. And yes, every decision needs to be time specific and decision specific as well. It's not just a blanket label. So we need to understand the workings of the Mental Capacity Act in practice. Then the Human Rights Act, there are two particular articles that we're talking about here. So Article 2, which is right to life. No one has a right to take another life, right? And any failure to protect life can become a legal issue quite easily. And it's no surprise that the coroner was brutally honest there to say, look, this could have been avoided, and we need to really review this and see what we can learn for other providers as well. Then Article 8, which is right to private and family life. So it includes being involved in life-changing decisions, right? So some people don't want their family involved, and as long as they've made it clear while they have capacity, that's absolutely fine. But when I worked in the NHS, day to day, I worked in cardiology where we're dealing with people who have a heart attack. Heart attacks don't give you a warning. Normally, they happen. Whether you're on a plane, whether you're asleep at night, you're driving on the motorway. We would get people from all over the country because we're based in the Midlands. And the first thing you do is to call the family to tell them the bad news that their relative has been admitted. So you find the next of kin in, you call them, and then you talk to them because you get a lot of information from the family and their loved ones. It's really important to ensure that when we're making DNA CPR decisions, involve the person, involve the family, because nothing about me without me. We are breaching the rights of people there. Then the Equality Act, we talk about the 9 protected characteristics under the Equality Act. So we should not make resuscitation decisions, particularly not based on age, not based on disability, diagnosis. We need to look beyond that. So every decision there must be individualized and evidence based. No to blanket DNA CPRs like what happened during COVID, especially in care homes. It's, we can't do risk discrimination by default because people are older, right, or because they have a certain condition. So for me, those are the 3 elements that we need to look at. And I think we could spend a day just talking about each of them. But whatever we do, we should have a policy anyway for equality. We should have a policy that covers mental capacity and human rights. And part of our emergency policies as well have to address those issues.
Yeah. And we may sound like a bit of a broken record, but if we map those to sort of the CQC regulations, what are your thoughts on that?
So the key thing here is consent, right? Because the moment you talk about CQC, you're talking about enforceable regulations. So consent, which is Regulation 11, people must be involved in decisions about their treatment. If not possible, then the legal next of kin or representative must be involved as well. Then Regulation 12, which is one of the most commonly floated regulation about safe care and treatment. Care must follow clinical best practice, and that includes current guidelines, as like in this case, Resuscitation Council UK guidelines, and also the first aid side of things as well. Then Regulation 17, without good governance, we're wasting time. Nothing will work without good governance, especially in a regulated sector. You need to follow the prescribed governance, really. So you must have systems in place to monitor care decisions. You must have a system in place for auditing emergency care planning, training staff with real world application. The thing is, with resuscitation training, it's got a theory element and a practical element. The theory can be done online, that's absolutely fine. But actually, how do people then come in and practice that within your organization? Because risk assessment must be local. Because what will work in one care home in a different part of the country, or even within the same county, will be different in another care home, depending on many different situations. So it has to be localized. So yeah, Regulation 11, 12, and 17, those are the ones that are closely sort of related to this issue here.
Excellent. So, yeah, look, we've talked about what's been going wrong. We've talked about the legal and ethical duties that providers have. Let's try and put a positive stint on it in a way. How do providers go about fixing this now? How do we move on from some of these incidents we keep hearing about, and how do we prevent them?
It's about having systems in place, Lois. There's no 2 ways about it. So whether I'm setting up a new care home or a new care service, I need to think about the regulations. I need to think about enforcement actions, legal challenges, what sort of harms may happen to people. And once I've done that, then I need to do a needs analysis, right? Training needs analysis and organizational needs analysis. So who are the service users that we have? What sort of risks do they have? What sort of conditions do they have? Then our training has to be mapped to those, right? Because we can't just do things to tick boxes. Because if you're still hearing people say, "Oh, if there's a DNA CPR, we cannot help the person at all," right? That means you have a lot of work to do. Respect means no intervention, or everyone in a care home is one, right? Because people assume that if you're in a care home, you're not going to be for resuscitation. So we need to debunk these myths and actually set up good systems that help with the initial statutory and mandatory training as part of the induction, then the refresher training, as well as the supervision and monitoring, even our care planning and record keeping. Whenever people have any changes in their care, are they being updated accordingly as well?
Excellent, excellent. So, if we wanted to expand a little bit more on that, what do we actually need to do? In layman's terms, let's say.
So we go back to the training, for example. You did mention scenario based training, which is really crucial in this case. I remember the days when, you know, in the early to mid 2000s, we used to do advanced life support training with our NHS Trust. And what would happen is that you'd be registered with the Resuscitation Council and you get your booklet. You spend about 3, 4 weeks going through your booklet, understanding the guidelines, the different types of interventions and medicines. Then you write a test on the day, And then once you finish your test, you finish the theory, then you go to the practical stations now, where you are now applying the skills, how to manage the airway, how to do chest compressions, how to manage a resuscitation scenario, how to use an AED safely. So e-learning is great for theory, but actually, how are people going to apply it in practice? Simulation is
Yeah.
crucial. You know that even when we do our resuscitation training with providers, we do a lot of simulation and put people under pressure to try to mimic the real life situations, and also real documentation as well. How do you report? How do you hand over to the ambulance crew? How do you hand over when somebody's going to the hospital? Staff should always know how to act. So you test them by actually putting them in scenarios where they act as if they're in a real life situation, not just what the policy says, regurgitating what the policy is saying. They should be able to do it in practice under pressure. So training on legal and ethical frameworks is crucial as well. When we do our resuscitation training, we cover the legal framework and the ethical frameworks as well, and everyone should do the same. We should cover a bit of the mental capacity side of things, the documentation, escalation tools that are needed. So escalation pathways as well. Like in this case, they did the right thing to call the ambulance, but even before waiting for the paramedic to arrive, they should have started doing chest compressions. But people waited for to hear what the paramedic was going to say. And there have been scenarios where we've gone to rescue organizations that were in serious trouble because of similar failings, where you have to start again and say, look, let's look at the policy. What does it actually say? Now let's map the training to that. Now let's remind people what they need to do. So you deliver the theory, and then you do the practicals, and then you remind them what their policy says as well at local level. So access to documents is really crucial, especially emergency care plans. The challenge we have in most care settings is that sometimes actually people have access to only the things that they are doing day to day. They don't have the full care plan. So even knowing who is for resuscitation or not for resuscitation, sometimes that information is not available to everyone. And also now you have to look at, is it up to date? Because sometimes people have an order that is then reversed, say after 72 hours. It's no longer valid. So the document that we have, is it actually still in date? Is it easy to interpret? Are the instructions clear? Because you can go back and get the instructions clarified if you're not sure. So it's got to be accessible even on night shifts, on weekends, on bank holidays, because usually it's in the manager's office and it's locked away when they're not there. So if a staff member or a paramedic can't access the care plan in real time, then new risks arise there. Like in this case, it was there, but people misunderstood it.
Mm, yeah, like you say, in an emergency situation, that's all pretty terrifying. So what we're really saying is what's needed is scenario based training, mental capacity, consent, interpreting documentation under pressure, clear escalation pathways, which I know you've been very passionate about in other episodes we've done, but then also the real time access to accurate documents, like you say, in particular the respect forms and so on, so that people can make decisions and act as quickly as possible, which could, like you say, save a life.
Definitely, definitely. I know you're passionate about digital compliance, and you are sort of talking about digital tools every day on LinkedIn. Digital systems can close the gap between policy and practice. We developed ComplyPlus because we saw the need on the market to say, look, we're going to do training, but training is done maybe once a year, right? What about the rest of the time? What are people actually doing? So if we build a digital platform that links policy and training and then day-to-day use, that makes a difference, right? So you want a system where you can store your key documents, and it becomes very clear, even the care planning systems actually, who is not. Maybe you can do color coding as well. People have got a lot of innovative ways of doing that. But also you want to make sure that only people that need to know have access. You don't want unauthorized access to devices or systems, digital systems. And version control is crucial as well, because sometimes with digital systems, people will end up with different versions. And if things are not kept up to date or labeled clearly, then decision making can be affected. I know you're passionate about learning management system and training management system, because a lot of companies do have learning management systems. Maybe they're licensing them, but their training management is still done manually. So there's a discordance there between what we're doing digitally and what we're doing. It's not connected. So with the system that we've built, you can actually upload documents so that everything for training compliance is in the same place. Dashboards as well with audit trails. I'm always fascinated to hear what people are doing. And even some of our competitors actually have come up with some really fantastic dashboards. And we have to keep learning as well and updating these systems to say, look, you need to know who has been trained and who's due for training and who's running out. You need to know what decisions have been made on particular residents or clients in a care setting, and also the risks and gaps in the organization as well, then doing something about it. right? That's really crucial. And even in near miss situations where something nearly happens or people make a poor decision, which is then corrected and something is done about it, you can still do your root cause analysis and try to understand where the gaps are. So, when you think about it with resuscitation, when the heart stops, you've got a few seconds to quickly make a decision, and then every minute that goes after that could, you could either save the person or not. After 3 or 4 minutes, there's hardly anything to save there. And by the time you call the paramedic, they spend about 8 minutes to get to you. The person is dead. You're not going to get them back, no matter what happens. So you don't want people to be flipping charts and folders to try to figure out what the document is saying. You want people to be absolutely sure what needs to be done so that lives are not lost needlessly. But obviously, the right training, have good systems in place, have good governance, turn chaos into clarity, and avoid any guesswork actually when it comes to the decisions that you make when you are rushed, when something happens in an emergency. Yeah.
Mm. Okay, excellent. So if we sort of come to sort of the final parts now, in terms of the top five actions for care providers right now, what would be your top five things for people to get
Mm.
in place on the back of this horrible story? Yeah.
So, if I were a registered manager or an owner or director of a care business, the first thing I'll do straight away is to review all of the DNACPR and the ReSPECT policies. What do our policies actually say? I'm amazed at the number of times I see the same templated policies that don't even apply to that particular organization. Sometimes they don't even bother to remove the address from another company. They just got it from someone and placed it in their folder, right? So you need to make sure that they are relevant to you, they're current, and they're legal. Then number two, deliver scenario-based statutory and mandatory training covering resuscitation or first aid. Make sure that DNA, CPR, and ReSPECT is covered. Make sure that people understand how decisions are going to be made. People understand about consent. People understand about Mental Capacity Act. Then you want to audit your compliance system. So whether you have paper-based systems or digital systems, audit everything. Do things make sense? Are policies linked to the training needs analysis and the matrix? Document control, real time availability of documents as well, and test your people as well to make sure that they can connect. Because when you're training internally, you can actually use some of your documents, your actual documents, unlike sending people to a training company somewhere. If somebody is training people internally, whether they're an external training provider or its internal team, you can actually help to design the training yourself. Don't just default, leave it to them. Then number four, you want to invest in digital regulatory compliance tools that support decision making and governance. There are so many systems out there, but some of them are not fit for purpose. So you need to get the demos, you need to test them, you need to see where they fit within your current framework. Because sometimes actually system may be very good, but actually maybe your staff are not ready to use such a system. Maybe there are several things that you need to digitize first before you take some of these digital platforms. Then the last part is reflective practice. Make sure that you embed reflective practice in your organization. So, as part of your onboarding and induction, supervision as well, debriefs when there are emergencies that happen, and even when things go wrong, how do you debrief so that people can then learn from any of these situations and be able to act properly in the future. Then make regular reviews as well. Audit your own systems. You don't necessarily need to wait for an external auditor that you're going to pay huge amounts of money. You can use basic audit tools, with some of which we're giving for free on LinkedIn, on Facebook, and you can just sign up on our systems and download them and use them. Because for us, actually, even if it's just going to save one life, then it's worth doing, and it's worth actually us investing in this platform so that people have access to the right information.
So yeah, there are five takeaways for any providers or people running these sort of businesses right now. Please do take time to listen to those and make time to do those because it could save a life. So, Richard, any final thoughts on this particular episode we've done? Obviously, as I know, you've got a lot of passion for this area. You know, it's one of your, let's say, more favorite subjects from a content perspective. So, do you have any final thoughts on this before we wrap up today's episode?
Look, resuscitation is not just a medical decision that is deferred to GPs or consultants in hospitals. We are looking at our legal responsibilities. We're looking at the ethical side and governance as well. It's everyone's responsibility to know what needs to be done in case of emergencies. And as we have seen in some of these unfortunate cases, misunderstandings cost lives. And we need to make sure that we've got the right policies and procedures in place, the right training, good systems, including these digital platforms that we're now using. we want to prevent tragedies like what happened to Kathleen Gregory in Suffolk, and we don't want this to ever happen again. But sadly, every month, actually, there's always a situation where you think this could have been prevented. And I think it's about time now we take our responsibility seriously. And even the regulators as well, I know they're going to come down hard on this because, we are going to have many organizations that continue to fail to meet even the minimum standards that are required for health and social care companies in England and across the UK.
Excellent. Thank you very much. Yeah, definitely echo those thoughts. And like you say, you do feel a bit of a crackdown is coming in this area. So, as I just said, if you are a provider, write down those 5 things and make some time over the next few days, because it could be you next. So, yeah, look, thanks everyone for listening to today's podcast. A little bit left field, but we thought it was highly relevant. And it's really important we spread the awareness on this topic and make sure that lessons are learned from the case with Kathleen, um, as Richard said earlier on this week. So we are going to be putting some resources out on this. Our team are looking at some free resources and tools and guidance sheets that we can potentially provide to some of you providers out there, but also people actually working in these settings as health or social care professionals, just so that you, in your particular role, in your job day to day, you have awareness about these documents, about how to act. But also, we're going to create some for providers as well. So keep an eye out on our website, keep an eye on your emails. Many of you that have subscribed will be on our mailing list, and we'll get some information out on those things, I think, in the next week or two at the most. So, yeah, please keep an eye out for that.
We'll put them on LinkedIn as well, Luis, on LinkedIn and Facebook, because these are resources that you can just download straight away and use. You don't even need to be a registered customer, because we feel that even if you are not directly our customer, this is something that needs to be addressed, because it could be any of us actually that need people to intervene in emergencies.
Definitely. Excellent. So thank you very much for joining me again, Richard. And as always, if you've got any comments about today's episode, please do comment and share on the usual channels. And thank you very much for listening.
Thanks, Luis. See you soon.